Okay, let's get straight into another deep dive.
This is good.
We're tackling a pretty crucial topic today, hypertensive nephropathy. And we're using your revision notes as our guide, really.
Exactly. The plan is to take these notes, cut through all the detail and pull out the absolute must-know stuff.
Make it high yield, make it stick. We're navigating your material, finding those key bits together.
That's it. And these notes give us a really good structure, actually. They show how chronic high blood pressure, something that sounds simple, can cause serious kidney damage, often quietly.
Right. So we'll follow that path. We'll look at defining it, why it happens, who's most at risk,
How it actually damages the body, what it looks like clinically.
how you diagnose it, and crucially, what can be done about it. Management, prognosis, the whole picture from these notes.
And really understanding that connection high pressure hitting the kidneys is so important. It underlines why managing blood pressure isn't just heart health, it's vital kidney protection too.
Definitely. Okay, so let's start right there. The definition. What exactly is hypertensive nephropathy, according to these notes?
Well, at its heart, it's kidney damage that's caused by having high blood pressure for a long time. Simple as that, really. The kidney suffers because of chronic hypertension.
And is it general damage, or does it target a specific part?
The notes are clear here. It specifically targets the vasculature, the blood vessels within the kidneys.
Ah, okay, so pressure on the pipes, essentially.
Pretty much, it's vascular injury. And the notes show a progression from this initial damage. It can cause nephrosclerosis.
Which is like hardening or scarring?
Exactly, hardening and scarring of the kidney tissue. And that can then progress to chronic kidney disease, CKD.
And CKD, just to be clear, is that gradual loss of function over time?
That's right, a persistent ongoing decline. And if it keeps going, unfortunately, it can end up as end-stage renal disease, ESRD.
Which means kidneys failing to the point of needing dialysis or a transplant.
Precisely. That's the end of the road for the kidney's own function. And importantly, right, in this definition part, the notes flag the main treatment idea: lower the blood pressure.
Right. It's the core strategy from the get-go.
Absolutely. To try and stop, or at least slow down, that whole progression.
Okay, so that leads perfectly to the why. Etiology. How does chronic hypertension actually do this damage?
Well, the notes state the primary cause is just that sustained high blood pressure. It's the constant, relentless force pushing against the walls of those tiny kidney blood vessels year after year.
Just wears them down?
Yeah, it damages them, impairs how the kidney works, and even causes physical, structural changes in the organ.
So who needs to be most aware? Who are the high-risk groups mentioned in these notes?
Okay, several risk factors listed. Unsurprisingly, number one is uncontrolled or poorly controlled hypertension itself.
The worse the control, the higher the risk.
Makes sense, doesn't it?
Yeah.
Then a family history of kidney disease is also flagged. Older age is another factor.
Any specific populations mentioned?
Yes, the notes specify African or Hispanic ethnicity as groups with higher risk. And then there are the broader cardiovascular risk factors, things like obesity, diabetes, smoking.
They all add extra strain.
Exactly. Extra stress on a whole system, including those kidney blood vessels, making them more vulnerable to the high-pressure damage.
Okay, let's get into the mechanism now, the pathophysiology. What's actually going on inside the kidney tissue when the pressure's high for so long?
Right. This is where it gets interesting. It's like a chain reaction.
Mhm.
The prolonged high BP first causes endothelial dysfunction.
Damage to the lining of the blood vessels?
Precisely. The delicate inner layer. This damage then triggers inflammation and oxidative stress within those kidney blood vessels.
And the result of that is?
Fibrosis. Basically, scar tissue starts building up in the renal vasculature.
So the vessels get scarred and stiff.
Kind of, yeah. This fibrosis, plus other changes, leads to narrowing and sclerosis, that hardening we mentioned of the vessels.
And less blood flow.
Exactly. Narrower, harder vessels mean reduced blood flow to the kidney's filtering units. And that directly messes up the kidney's main jobs, filtering waste and making urine. It becomes a bit of a vicious cycle.
It makes sense that other kidney problems might look similar then. What about differential diagnoses? What else needs ruling out?
Good point. The notes list several key ones. Diabetic nephropathy is a big one, obviously, as diabetes also hammers the kidney blood vessels.
Right.
Then there's glomerulonephritis, inflammation of the filters themselves, polycystic kidney disease, the genetic one with cysts, and just a general category of other renal disorders.
And anything specific to look out for during the workup?
Yes. Crucially, the notes flag up bilateral renal artery sclerosis, hardening of the main arteries to the kidneys, as something specific to consider during investigations. Got to make sure it's not that.
So you need to be sure the damage is from the general hypertension, not something else mimicking it. How common is this condition, hypertensive nephropathy?
Well, the notes say exact UK figures aren't readily available, so no hard percentages here. But they do stress it's a common cause of both CKD and ESRD. Very common, especially where hypertension has been uncontrolled for a long time. So the takeaway isn't the specific number, but that it's a major issue.
Right, a significant contributor to kidney failure. So what does it actually look like in a patient? Clinical features.
This is really, really important, and the notes highlighted. Early stages are usually asymptomatic.
Silent. People don't feel it.
Exactly. Symptoms tend to creep in only when the kidney function has dropped quite a bit.
And when they do appear, what are they?
Signs of the kidneys struggling. Things like protein in the urine proteinuria. Sometimes blood hematuria. Blood pressure might get even harder to control. Fluid retention, maybe less urine output, feeling tired all the time, swelling in the legs or ankles.
And are there more general symptoms listed that come with the declining kidney function?
Yes, the notes list those sort of classic later stage kidney symptoms too. Loss of appetite, itching, feeling really sleepy or drowsy, somnolence, weight loss, nausea, vomiting, sometimes a weird metallic taste.
Signs the body isn't clearing waste properly.
That's the gist of it, yeah.
Okay, so if it's often silent early on, how do you actually pin it down? How's it diagnosed based on these notes? Investigations.
Diagnosis hinges on two things: knowing the patient has chronic hypertension and finding evidence of kidney damage, seeing protein, or specifically albumin, in the urine albuminuria is a key sign that kidney filters are damaged.
What specific tests are mentioned?
Well, first you confirm the high BP, obviously. Blood pressure check. Then, blood tests are crucial for kidney function serum creatinine and the estimated GFR.
The eGFR.
Exactly. The notes also mention checking things the kidneys usually balance, like potassium, calcium, phosphate, bicarbonate, and checking for anemia, which often goes with CKD.
And urine tests.
A basic urine sample checks for that albuminuria. If it's there, often a 24-hour urine collection is done to see how much protein is being lost. The notes specifically mention the albumin to creatinine ratio, the ACR, as helpful too.
What about looking at the kidneys? Imaging.
Yep. An ultrasound scan is standard. It checks kidney size, shape, looks for blockages, assesses blood flow.
And biopsy.
The notes say a kidney biopsy might be needed if required. It's not routine for everyone, but if done, the histology gives the definitive diagnosis.
Okay. And there was a mention of a pregnancy test.
Yes, for women of childbearing age. Probably because, as the notes mention later, some key BP meds aren't safe in pregnancy.
Right, makes sense.
And again, during these investigations, the notes remind us to think about that bilateral renal artery sclerosis as a possible differential.
Got it. So once you have the diagnosis, what's the plan? Management.
The absolute #1 goal, hammered home in the notes, is controlling the blood pressure. That's seen as the best way to slow down the damage.
How do you do that? Lifestyle. Meds.
Both. General measures include lifestyle stuff, diet advice, exercise, weight management, tackling other cardiovascular risks too. And then, yes, medications.
Is there a target BP mentioned?
Yes. Less than 130 over 80 millimilli-GZ is the target given here.
And specific drugs.
They mention loop diuretics, ACE inhibitors, or ARBs, angiotensin receptor blockers, but with important warnings.
Like what?
Don't combine ACEs and ARBs. And be careful with ARBs if kidney damage is severe because they can cause high potassium, hyperkalemia. Loop diuretics like furosemide might be safer then.
Okay.
And again, that reminder, ACEs and ARBs are not safe in pregnancy. Plus, the notes add that specific drug choices should follow local guidelines.
What about non-drug things like fluid and diet?
Yeah, it mentions water and salt, but it depends on the stage. For CKD, generally encourage water but limit salt. For ESRD, though, you restrict water because the kidneys can't handle it, and dialysis might be needed.
And protein.
A low-protein diet might help with uremic symptoms, but needs dietitian guidance. There's also a specific note on acute malignant nephrosclerosis that needs really aggressive BP lowering, often with potent diuretics.
And long-term.
It's about continuing the BP meds, closely watching kidney function, especially after med changes, managing those other CV risk factors. And if it progresses to ESRD, then it's renal replacement therapy, dialysis, or transplant.
The notes also mention something about renovascular disease management, narrowed arteries.
Ah, yes. Atherosclerotic renal artery stenosis. It highlights a bit of a debate, saying that generally good medical management controlling BP with drugs is preferred over trying to stent or surgically fix the narrowed artery. They even reference trials like Aspire and Coral to back that up.
Interesting. So fixing the pipe isn't always the best approach.
Apparently so, based on these notes. Medical management often wins out.
So what's the bottom line for patients? Prognosis.
It's described as variable. Depends on how bad the damage is already, how well the BP is controlled from now on, and what other health issues are going on.
But there's hope.
Yes, definitely. The notes stress that early diagnosis and good management can really slow down the kidney damage. It makes a difference. Better long-term outcomes are possible.
Good to know. And finally, complications. What are the main risks if things progress badly?
Several serious ones are listed. Worsening kidney function, obviously, potentially leading to ESRD needing dialysis and transplant.
We've covered that. Anything else?
Big cardiovascular risks, heart attack, stroke. It really highlights that kidney-heart connection again. Also electrolyte imbalances because the kidneys can't regulate properly.
And the key to avoiding these.
Same message again. Timely and effective blood pressure management reduces the risk of all these complications. It's the central theme.
So pulling it all together from these notes, the core message seems to be unchecked high blood pressure is a major, often silent threat to your kidneys plumbing.
Absolutely. It relentlessly damages those tiny blood vessels.
But getting that pressure under control aggressively is the best defense you have.
Exactly. This dive through your notes has taken us from what it is, why it happens, who gets it, how it damages, right through to diagnosis, management, and outcomes. And that link BP control and kidney health is the thread running through it all.
Okay, so here's something to think about based purely on these notes. We know the early stages are often asymptomatic, right?
Right. Completely silent.
So if you have a patient with known chronic hypertension, but no symptoms, how would you use only the investigation tools mentioned here, the blood tests, the urine tests, maybe ultrasound, to proactively screen for that early silent kidney damage before it causes problems?
That's a great point. It forces you to think about applying these tests not just for diagnosis when someone has symptoms, but as surveillance tools, because you know the risk is there and it's silent, using the EGFR, the ACR.
Exactly. How do you interpret them in someone feeling perfectly well but with that background risk? Something to ponder. And listen, if you want to really nail this stuff down, there are resources out there.
Definitely. Practice questions and structured revision can really help cement this kind of information.
Yeah, check out passmsra.com, and there's also freemsra.com for resources too. Worth a look.
Great. Well, thanks for joining us on this deep dive.
We'll catch you in the next one.